I now work as the clinical lead for our homeless program, which is based on the UK Pathway program. So our homeless team has been going for around 2.5 years. What I wanted to explore today, rather than simply telling you about our homeless program, was some of the knowledge that I've gained over that time with regard to how to get funding, because that's one of the most critical things. No funding basically means no work. So one of the things is to identify who in fact has control over the money that is could potentially go to funding homelessness programs, and the answer is it's not frontline workers, it's actually the bean counters. It's the people in the back offices who are there working out what they're going to allocate money to. And there's a very different approach then about what motivates them. So as a rule, they're not particularly motivated by the misery and the social justice issues, etc. What they're motivated by is stuff like this, which may mean making themselves and their department they represent look good, thinking about what it is that causes the most cost, particularly budget impact and cost effectiveness. So whether you like it or not, this is the stuff that drives them. But there's a flip side to this, which is if you want to start introducing innovation, doing things differently, the time to do that is paradoxically when budgets are tight. And that's because this is a time when people start to think about, we have to do things differently. And we had that experience in Western Australia where a relatively right-wing government got voted out of power and a left-wing government came in. But the left-wing government, state government, inherited a terrible budgetary situation with a very large deficit and rising health costs. And this was actually an ideal time to say, we have ways of doing things differently to meet the needs that you have to try and drive down costs. Because this is one of the big problems in all developed and underdeveloped countries, is that there's an increasing and insatiable demand for healthcare, and the cost of that is rising. And the key message, which is of the talk, and also for the bean counters out there, is this: homeless people are very expensive in terms of government services, and health is one of those. But if you try treating their health problems and you do not address the social determinants of health, which drive their healthcare utilisation, you are throwing money down the toilet, because these people will be on that carousel of representation, readmission, and as we've heard today, often with preventable illnesses, chronic disease that hasn't been treated adequately, because homeless people have very poor access to the things they need. And the real pillars in terms of improving the health outcomes and overall well-being outcomes of homeless people are stable housing, support services to keep them in stable housing, and long-term general practice involvement for their healthcare. And what we're trying to do in focusing on this message is to say that the health system, if it wants to reduce costs, needs to address those things as part of the healthcare package that you give to people. One of the ways that we did this was to show at Royal Perth Hospital that our no fixed address, so the worst type of homeless patients, were actually very high frequency patients. So we pulled some data out, thanks to our data. Well, this one actually came from Royal Perth, which is that 1 in 25 of all our ED presentations was a no fixed address patient. And we compared that to how many no fixed address patients were in the whole of that catchment area, which was 1 in 680. So that's something that gets the bean counters a little bit interested, because what we have is a relatively small population of people in our catchment area that are accounting for an enormous number of our emergency department presentations. But the other thing that really gets their interest was this: they're very high cost patients. So we took the first 1,000 patients that were seen by our homeless team, we took the first contact date. When did the team first see these patients? And then we used a linked system, so we have access in WA and particularly in the Perth metro area to all the health data, the hospital health data in the Perth metropolitan area. This was actually just calculating back 3 years within our health catchment area, and we just costed it according to basic bed day costs, which in WA we know from an independent pricing authority is $2,718 per day, which is around £1,000 per day, and an average ED visit or ED presentation at $764. So we did it in a very basic way, and we came up with $50 million, which is about £20 million spent on this cohort of patients in the previous 3 years. And the kicker on it is they're a young population, so you would not expect them to have very high healthcare costs. And the effect of that is this. And that is exactly what you want. And then what you can do is extend this further, because health is not the only government service which is seeing an excess number of homeless patients that are taking up a lot of their time. And the obvious other ones are policing in terms of move-on orders, in terms of prosecutions for crimes which are essentially crimes of poverty and need. The jail system is probably the second most useful in terms of costs, because I don't know what your daily cost of prisons are, but in Australia it's around $300 a day, which would be about £200, just under £200 a day. And when somebody gets a 6-month sentence, they start to really rack up the costs. The child protection and welfare system also racks up a lot of costs. And so what I see with that is this, is 4 sets of accountants who are very concerned about how much money the homeless population are costing them. And that's not because the homeless population, for example, doesn't deserve or need health care. It's because the social determinants of health are what drives their very high use of government services. And this is a great opportunity to push this message, which is you guys are wasting money unless you link with the services that are required to reduce the impact of homeless people on your services. So you have this dual message, which is that you can ask them to do the right thing, but in a language they understand, which is by saving money for them and doing things more efficiently and at lower cost. So where do you get money out of to fund these? And there are probably 4 major sources. The first is the bureaucracies of those government services, which in a time of fiscal restraint makes them much more interested than they usually would be in doing business as usual. So they may be looking for innovations in which savings can be demonstrated, and the Bristol Group is a perfect example of that, and why you had an early adoption to a long-term strategy is not just because there were the right people there, which, as I'll explain, is very important, but also because there is a significant cost saving that's been found. The next group, which is often untapped, are the corporate sector. The corporate sector's got a lot of money, as you guys probably know. They have, it's kind of guilty money for them because they know that there is a lot of inequality out there, and in order to try and improve their image, it's possible to harness some of that money into homelessness projects. So we have an example in WA where one of our big transitional accommodation services has partnered with a big mining company in Perth called BHP, and are now and they have donated or have a program where $1 million, which is about $600,000, is being used for a vocational reinsertion program. That looks good in terms of BHP. They're helping to get people back on their feet. They have a lot of influence and access to expertise in terms of the vocational stuff, including entry-level positions in their own organisation. And it's a huge boon where transitional accommodations are trying to move people back into full autonomy, which obviously involves employment for a certain number, and the more the better. So it is definitely possible to get a good image for the corporate entity, but also get some money which is often more generous than you would get out of the government bureaucracies. It can often be accessed much more quickly than the slow turnover of a government bureaucracy. Now, charitable organisations, which are often faith-based, can be another important source of funding. Our First Housing First program for very disadvantaged, chronic, complex homeless people, it's a program called 50 Lives, 50 Homes, was initially funded by the Little Sisters of the Poor, which was a religious organisation with nuns who, I'll actually correct that, St John of God Sisters, so it was a faith-based organisation. They provided an initial 3 years of funding, which was quite generous. What I can say to you, just to drop a large hint, is the Catholic Church, lot of money, image problem. Just saying. The other source which can be very useful is tapping into philanthropists. And one of the things that's interesting about philanthropists is that they often have very unusual interests. So they may, tapping into people who have had a lived experience, who've had an epiphany, something's happened, may be interested in investing quite a lot of money into areas that are pretty unloved by others. So again, you can often find quite generous amounts of money and in areas that appear very unloved. And we've also had that experience with a philanthropist from Sydney, so we're about 4,500 miles or kilometres away, who is funding our Street to Home program and has funded it for the last couple of years. Again, something that's been quite difficult otherwise, but she believes very strongly in that work. What these organisations all want is this sort of stuff, and that's where having a good program is important, because what they want is data. They want to know that there is evidence base behind it, that there may be some experience elsewhere in showing that this sort of intervention will give them value for money, particularly when you're talking to people in the corporate sector and in health bureaucracies. They want results. They want to get a good outcome out of it, but they also want to make sure they're not just throwing money into a sort of non-governed nebulous pit. So they'd like some good governance structure around it. And what you want to look for when you're getting that money is to try and get money which is not about process-driven design, but outcome-driven design. And the example is that in many bureaucratic organisations, what they want you to do is deliver, for example, a certain number of services. The problem is if you start the project and then you find that that process doesn't really work that well. For example, they want GP services delivered in a GP surgery, but actually you can't get homeless people to come there, so you now need to start going out into the community to find them. It's very difficult if everything in the project is based on you delivering services in a certain way. And what you want is to get outcome driven. We are going to sign up, provide GP care to a certain number of patients who are currently rough sleeping. How we do it is up to us, so you can then change direction. And we are currently trying to get this changed over in our Department of Communities, on which I sit on a ministerial advisory board, is to ask them to go outcome driven, to give organisations a chance to be able to innovate, truly innovate, change course and get the outcomes that they want, rather than being really bound by process. This is an example of how being flexible and outcome-based is important. We got last winter, we got some homeless brokerage money that was provided by the Department of Health, and so separate from the hospital. And when the hospital got hold of it, they said, "What are you going to spend it on?" And we said, well, kind of anything. I mean, repatriating people back to the country, paying for accommodation directly, really whatever it takes, paying off a debt to a housing organisation so the person can be accepted. And they said, well, well, that doesn't sound like what we should be spending the money on. So we went back to our funding provider and said, can you tell them we can spend it on anything we like? And that's what they did. And in fact, we spent £200 out of a lot more, about £20,000. We spent it on contributing to the repatriation of a Great Dane back to New Zealand. And the reason for this is that the Great Dane was owned by a New Zealander who needed to go back to New Zealand. She had no recourse to public funds, wanted to go back to New Zealand, but on the streets, her protector, her companion, everything was a Great Dane. And she would not leave Australia or Perth without the Great Dane. But to get this very large animal back to New Zealand required building a special crate for it because it didn't fit into the sort of pet flight crates, which cost about $2,000. So the homelessness organisations around Perth all chipped in a little bit, and we got the money together, and the Great Dane and its owner went back successfully to New Zealand, which was the best outcome for this young woman possible. So we did use it very flexibly. Health economics is what really this boils down to, and using health economics, because what they're up to is maximised health with constrained health producing resources. And there is nowhere where the health system has money to do everything for everybody that everybody would like. So what we've done is we've harnessed in some, they refuse to be called health economists actually. Lisa Wood is sitting up the back there tweeting and probably tutting a bit. In the University of WA Home to Health research team, we've teamed up with them to really try and get the most effective use of what we're doing out. Because there are kind of two approaches. One is the kind of kumbaya, let's all get warm and fuzzy together in a room, and that is an important part of things. But if you want to extract money, this is actually the stuff that's most effective at doing it. I'm going to talk just a little bit about the experience at the Royal Perth Hospital. We have a pathway team which is based really on, it is the English model transposed into a sunnier and warmer and less rainy climate. That's resulted out of a few things falling in the right place. This is a photograph of our team on one day. We have a homeless healthcare GP and nurse from our local specialist homeless medicine GP practice. That's me. I'm just the Royal Perth part of it, just schmoozing the hospital so that the team can do its work as well as possible, because a big hospital is a scary place for outsiders, and we have an administrative assistant who glues us all together. What's not in there is a community caseworker who's actually employed by the hospital to provide community outreach in terms of housing and supports. Now, this person you'll recognise. When the head of the homeless healthcare GP practice, Andrew Davies, and I came to London to have a look at the teams here, we asked the question of Nigel and Zana Khan as well. We said, if you started Pathways all over again, what would you do differently? And the answer from Nigel was that we needed to collect data. And we really made that a priority to collect the data. There's one thing to collect the data, but if you actually really want to make the data sing, what you need is to get the people who can use the data. So Jim O'Connell is a kind of invader in there, a very welcome one. He's from Boston and has about 30 years experience of working with the homeless, and we took a photo when he visited last year. But really what you get to is this alchemy that happens when you mix clinical data and the academic minds of population health or health economists in that academic. You get this alchemy, and what you produce are things like this. So this is a recently released report. What I have got for you is not copies of that report, which is about 80 pages long. I'll go through a little bit of the data, but what we have got, if you'd pass me one of those, is, and this is another thing that happens when you team with health, with academics, is we have a report on the homeless team which is only 4 pages, but you have a Q code to the entire report. So we'll distribute some of those, and I think we've probably got some more copies so that you can see the entire report if that interests you. And what we have here are probably the two key elements here on the cover. Andrew Davies, who is the director, the founder of the Homeless Healthcare GP practice, our community caseworker, and we have the most important person of all, which is, this is in fact a real patient who was happy to be photographed. You can produce stuff like this crazy, beautiful diagram which shows the interaction between the different sites of practice of the homeless healthcare GP practice, including Royal Perth, but also including transitional accommodations, women's domestic violence shelters, a drug and alcohol rehab facility, a homeless drop-in centre, the street health program, and transitions, which is their almost normal GP practice. And so we're able to trace where in the network of services in primary care where our patients have been. We can produce simple stuff on the homeless team patients of who they are, women, their age, whether they are of an Aboriginal population or not, also where they were born, which then helps us to overcome stereotypes that all homeless people in Perth are Aboriginal or immigrants or refugees. And in fact, the vast majority of them are actually white Australians. Where are they living? So on their first contact, we can show that the majority of them, sorry, we haven't got a percentage there, but it's about 75% of them were rough sleeping when we saw them. We are seeing people in long-term housing. That's because they were homeless before, but they remain patients of homeless healthcare as long as they want. So these are generally social calls. These are business calls. We can also show on the episodes of care, and our average, I think, is about 2.1 contacts with the homeless healthcare in terms of either an ED presentation or a hospital admission, but where we're able to get them. So this number is the 1,000, and this is 2.5, probably nearly 2,000 here. We are still having to discharge a lot into rough sleeping because we don't have alternatives, sometimes because patients have left, but we have a spread of other options that we explore. We can also look at why they came to hospital. We code for each presentation a primary diagnosis, what was the thing that actually brought them in the door, what was behind it in two more categories, to try and capture some of the complexity of why patients present. And what we show here is that the majority are primarily presenting with either injury or illness. It's not that they are presenting primarily with social problems, and that won't be a surprise for you. But in the secondary reason, there is often alcohol and drug issues behind it. And in that third one, often social issues. So the social issues often underlie it, but they're part of a much more complicated presentation. We've got some statistics on, and these will be underestimates about what levels of psychiatric diseases, mental health issues there are. This, for example, shows is at about 11 or 12%, which is around 10 times the population average, well, the population percentage of 1% for schizophrenia. We're looking at 11 or 12%, so overrepresented within the population that we're seeing. And in terms of drug and alcohol issues, again, an underestimate, but you can see the impact that the methamphetamine epidemic has with us. We see a lot of people who are using methamphetamine, and the move has been to high purity methamphetamine, which is injected. So we're seeing a lot of the complications of injecting drug use. Alcohol obviously is a major problem. Opiates, as you can see, are less of a problem, but one of the problems where the methamphetamine group starts to inject drugs is that when meth is in short supply, people actually switch between the two. And that's not good. We showed the cost savings, so this is the figure of the 50 million that you saw before for our patients, and we can start to horrify our executive with the number of aggregate ED presentations and the aggregate number of inpatient bed days, and start to put some figures both per person and per year. It actually is generally better to use the biggest figure that you've got, though. 50 million speaks volumes. This is the money shot, because what they really want to know is, did you save us money? So what we looked at here is the costs in our health area, East Metropolitan Health Service, hospital utilisation 6 months and 12 months before and after their first contact with the homeless team. And with a big data set, you can do that. So what we showed is in the largest cohort, because obviously these people, we had more people who we could get data for 6 months than 12 months, but we could show in this group that we reduced ED presentations and we reduced bed days and we saved nearly $6 million. Which for them, we were actually not sure if we would find anything, because obviously a first contact with a homeless team is not housing, it is not stabilisation, but we were able economically to show an impact. And when we looked at people who we had 12 months of data pre and post, for that you need 2 years of data, which we had only just acquired, presentations up a little bit, but still a decrease in bed days and still an overall saving of just over $4.5 million. So when we presented this data to our executive a couple of weeks ago, they were happy, and that made us happy. What happens when you get when you get these outputs, you can use them to do reports, to do papers, to produce these figures, but very importantly, to pass the baton. The data that we produce is now helping teams in Cairns and Sydney and hopefully soon Melbourne to set up their own pathway teams. They're leapfrogging off the data that we've used. We use Pathway, and then we're going on to help other teams with the figures we've got and looking at these things. Money for pilot projects, grant applications, we're all hoping for this, and this long-term funding. In the home stretch, if you look and find the need, all of these services are dealing with a lot of homeless people. They're feeling pretty hopeless. They're feeling like they're spending too much money on them. They're not spending too much money, but they aren't spending it very wisely. If you can identify with them the problems, one that we have identified but not worked on yet is our prison system tells us that if they release a person outright to homelessness, there is an 80% chance that person will be back in prison within 12 months. That is an opportunity for funding, because they need then to team with a prison outreach program which will cut that down. That is going to be very cost effective, because a prison cell costs $300 a day, and the average rental cost for a 1-bedroom flat in Perth is $300 a week. So it's an easy transfer. My advice to you is just do it. If you've got an idea, just get on with it. The 50 Lives, 50 Homes program, we started probably with the rough sleepers, started with maybe 10% of the funding it needed, just got on with it. Funding came along the way. Finding the right people. So it's true that if you find the right people within organisations, and actually they may not be the frontline people, it may be appealing to the accountant, to the bean counter, who actually doesn't really care about social justice, but he does care about the bottom line and the budget. And sometimes that can actually be fairer than asking people to do it for social justice reasons. Because in social justice, people will often find people who deserve and people who don't deserve to be helped. Whereas when you're just using straight out money, then sometimes it's just, well, we should do this for all. So for example, people leaving prison are often considered not worthy of help. If you look at an economic case, oh yes, they are. Find the right people in the organisations and have projects ready to go. Your housing, the Housing Act that was passed, I think 2 years ago now, with the responsibility for homelessness, that was entirely about this. There was a project ready to go. So if you've got ideas, start putting them together, writing about how you would get going. It might be that you do a tiny pilot on an observational thing on your patients, get some data from elsewhere, get stuff ready to go, and then rise, go forth and conquer. Thank you.